Beds, good for dead people, good for sleeping at night, only at night, not during the day. You shouldn't be sleeping during the day, and good for sex. But in nursing homes, you can have sex, but not in hospitals, okay? So those are the purposes of a bed. There are no other purposes. Please remember that. And please remember the same is true in a nursing home. You want everybody out of bed. You don't want them to spend their day in bed. If you spend your day in bed, you're going to fracture, you're going to run into trouble. So somebody brought up physical restraints and said this is the reason for falls. Well, physical restraints exist for one purpose only. Just so we all understand what a physical restraint exists for. It exists because whoever's putting it on wants to have bondage with their mate, but unfortunately their spouse or mate will not do it for them, and so they've got to do it with an old person. There is no other reason. There is tons and tons of data that show you will kill people with physical restraints. You will increase falls. You'll run into trouble. So, you know, if some of you are so desperate to have bondage, I offer my body up, as I have done forever, because my wife refuses to do it for me, and I want to try it, okay? That is the only reason for physical restraints, and I'm available, okay? I'll tell you how to get hold of me later, okay, if you're really desperate. Sounds like a lot of fun. I'm teasing, but only a little bit, because I really tried for years, and the one thing I found that works is when I say this, restraints go way down wherever I say this in a hospital or a nursing home, because the next time a nurse is going to put on a restraint, she thinks, wait a minute, everybody else heard him say this. They're going to think I want to do bondage. You know, it really works. I mean, so that's how it is. So it has worked for a long time. We need to point out that many, many studies have shown that when you reduce restraints, you actually reduce injuries. Falls go down after a while. They actually go up, as I said, to start with, but they go down after a while, but injuries go down dramatically. So restraints do not stop injuries. Now, for the OTs here, a positioning device is not a restraint. There are some people who can't get out of bed without a positioning device. A Mary Walker is not a restraint because it allows somebody who can't walk to walk. So we have this problem sometimes communicating with state or communicating with the different nursing home chains who think that some of these things are restraint. Something that enables you to do something that is useful is not a restraint. Something that stops you doing something, like getting out of bed, that's a restraint. So there is a difference, and we need to be very aware of that, because otherwise you'll run into trouble and say, well, I can't use the positioning device, so you leave the person in bed, and I see that happen all the time. This is just one of the nursing home studies. This was around the country, 2,775 beds in 16 facilities. Restraints basically went down from 41% to 4%, and injuries from 7.5 to 4.4%. Lots of studies showing this, so let's be aware of it. And please remember, a Foley catheter is a one-point restraint. There is no purpose, if possible, of Foley catheter. The straight in and out catheterization 4 times a day is preferable to a Foley catheter. It's preferable to a condom catheter. All of them increase infections. One of the major reasons for falls is infections. Plus, if you try to get out of bed and you're demented and you forget you've got a Foley catheter, you're pulling like this, it's hurting like mad, and you know, in the end, you're going to fall. I mean, it's very simple and straightforward. So please, let's try and remember this. Okay, let's look at the causes of falls now. And we know from the young person who walked in here earlier today that if there's something that's uneven on the floor, you're liable to trip on it. So uneven pavements, poor lighting. This is particularly true in the areas near the toilets in nursing homes, but when people come home at night, older people come home, they need to have good lighting, particularly if they have 1 or 2 steps getting into their house that should be set up so that when they come home the lights go on. Otherwise, they're going to fall. People don't adapt well, yeah?
What I found mostly in steps with older people when they come in to be with us is they miss the last step.
Yeah.
And so what we've come up with basically is, you know, people say it's a lighted step. Yeah, but the floor's not lighted.
That's what, yeah.
That's the problem.
It's sort of like playing baseball in Milwaukee, where they have this special kind of lighting that only the Milwaukee people can play the baseball in. If you watch the Cardinals struggling in Milwaukee, they do it very well. Your lighting has to light the fall. And you're also wearing glasses, right? Are yours bifocals or trifocals? And when you get up and you walk out, what do you wear?
I go like this.
You wear your trifocals. So there are now 2 very good studies that show that people who wear multifocal lenses actually are more likely to fall when they go outside, and they're more likely to trip. So you're either better off taking them off or having a separate set of glasses for outside. You should never let an older person walk a distance. It's in the house, it seems okay. They don't get great outcomes. Small reductions, but not statistically significant. But outside, very important, and that's one of the reasons for missing those last steps. The other thing is, as you get older, it's nice to have something to hold on to. I climb steps all the time, but I feel much happier when I'm climbing my 12, 14 flights of stairs at the hospital if I've got something that I can put my hand on as I go up, just to steady me, because sometimes I trip over them, not looking in a hurry, thinking of something else. There are lots of things that cause you to get into trouble. No grab bar in the toilet is basically an important thing, and the stairs are cluttered or the house is cluttered. One of the first people in geriatrics I ever saw was a person who kept on coming into the hospital with falls, and he had like 20 falls that got him into hospital in a year. And eventually an OT went out and looked at his home, and there was magazines everywhere. And then the OT said, "I'd like to get rid of these magazines." And he said, "No, these are, they're very important to me. I mean, you can't move my magazines." So a negotiation took place where he agreed to leave pathways to the bathroom, to the door, to the kitchen. And they created these stacks of magazines for him, which were all over the place, but there were the pathways. He went the next year without a single admission for a fall. Great outcome for an OT, thinking out of the box a little bit, because the real box was just get the stuff out of the house. But if you'd done that, he would have continued to fall because he just put more stuff in. So it was a really good outcome. So remember these things, be aware of them. There are lots of causes intrinsically, and those are what we're going to focus on. Low levels of vitamin D we've talked a little bit about already. We'll talk about blood pressure. We'll talk about medications. We've just mentioned poor vision. Vision is a big problem, particularly outdoors, and we need to recognize that. Glasses, very big problem if they're not using them properly. Poor balance, muscle weakness, gait problems, all of those are very essential. Dementia, a poor ability to dual task. Depression, people who are depressed don't pay attention, tend to fall. Loss of consciousness, syncope, and seizures. And basically, a lot of people have seizures that you don't recognize. I mean, if I lie on the floor and I'm jerking like this and incontinent, we all know it's a seizure. But basically, about 5% of seizures, and then they go on. So I'm having an absent seizure or a petit mal. It's there and gone. Those will cause me to fall. And then the big group are these partial complex seizures, where I start buttoning and unbuttoning my shirt. It's a seizure. It doesn't go to a grand mal, but I still have the post-ictal state where I tend to fall. So those are about 52% of seizures in older people. So if you see strange behavior, the person suddenly starts brushing their teeth, and there's no toothbrush. Think about these things, recognize that can be a seizure. Those are fixable. Okay, now I need a tall male. Either one of you, yeah. I was going for your friend, but you just won, okay. And a short woman, a really short woman. Come on, who's going to volunteer to say I'm short? Oh. Okay. You just saved her. That's very good. You're not that short, but it's okay. So I want the two of you to come stand over here.
If I take my shoes off?
Oh, no, you can keep your shoes on. You're going to do really well, unless I'm very mistaken. The poor guy's going to look really stupid by the end of this, so it's okay. Unless I'm really mistaken. I do get faked out by people occasionally. So all I want you to do the first time is when I say go, just walk towards me, both of you. I haven't said go. This is not a race. Walk at your normal pace. Go. Okay, and the guy just about wins, which is really sad, so he's in real trouble. Go back. Okay. The hardest part is to get people to follow instructions to show this, okay? So, in your case, when I say go, you just do what you just did. Nothing different. Do you think you got that? Sometimes it doesn't work. I say go, you don't move. I mean, I've seen this all the time. Now, in your case, sir, what are your names?
I'm Jim.
Becky.
Okay, nice to see you, Jim and Becky, and I'm really sorry, Jim, that I'm doing this to you, but that's okay. So when I say go, as you walk, and before you can start walking, I'll say, give you a number and say, take this number away from the number and continue to do it. So I'll say, take 3 away from 10, which is 7, 4, 1, minus 2, minus 5. And you've got to yell that out so they can hear you as you walk. Okay, so for him, not you. No, you're just going to walk when I said, what? You walk when I said go. I'm talking to Jim now. I've left you alone, okay. You just do what you did before. You see how hard it is to get people to listen, okay. So, Jim, what I want you to do is take 7 away from 652, go. Why? I haven't heard a word out of you.
6:45. 6:38.
Yeah, well, you took 5 steps before you started.
She threw me off.
Yeah, I know. We understand.
I'm blaming it on her.
Okay, go back there. We'll try it again. Okay, it's not going to do any better, but he's actually fairly good. He's one of the few people who got 1 number out. That is really good. Okay, so.
Same number?
No.
I do it.
So, are you ready? When I say
sir.
take 6 away from 1,922, go.
1,900 and...
Wait, you haven't said a word yet. Go by. I think she won very easily.
I'm terrible.
Thank you very much. You can sit down. Okay, give them a round of applause. So what you saw there is dual tasking. It's when somebody is walking and they get distracted, they're talking to somebody, they're much more likely to fall. If you've got dementia and you're losing your executive function or mild cognitive impairment, your fall rate goes up super high. Why am I showing you this? Because you can actually take, and you see this, the worst is in Parkinson's patients. Parkinson's patients actually have real problems. So a physical therapist can actually take someone and either have them take 7 away from 100 or 3 away from 10, something simple, or just walk with them and distract them. And if you do this as part of the physical therapy, the dual tasking problem will disappear. This is actually a trainable problem. So recognize and be aware of that, okay? Something that is not often fixed, but is very fixable if you work with people to get it fixed. So, if somebody starts falling and has 2 or 3 falls in a week or in a couple of days, the first thing you think of is they've got delirium. The most common cause of delirium is going to be urinary tract infection in a nursing home, and people who are delirious fall. Need to be very aware of this and pay attention to it, because if you don't go and treat the delirium, they'll continue to fall. Eventually, they'll also possibly die from the septicemia or something. So you have to recognize. Now, what does this mean to the nurses here and to the nurse administrators? It means, or to the administrators, sorry. My daughter would kill me. She's an administrator, not a nurse, and I said nurse administrator. I am in real trouble. Okay, so please don't tell her if you see her. Okay, so basically being careful here. What does this mean? It means that you'd have to teach the nurse when they phone the doctor to say, I'm phoning about Mrs. Smith. This is her 3rd fall in the last 2 days. Because even if you call me and you call me 3 times, I may or may not remember after 40 calls in 2 days that Mrs. Smith was 3 of the falls. So I try and remember when people call me, well, has she had any other falls in the last couple of days? But it might have been in the last week. And it's very important to communicate that, because then the question is, do you think she may have or he may have delirium? Can make a big difference. We've just talked about dual tasking for dementia. Older people with dementia are twice as likely to experience a fall compared to similar age groups. This is true for the community and everywhere else. Elders with Alzheimer's disease have a greater disturbance of gait and balance. Their step length is shorter. They tend to have a sway that is different, and the the step-to-step variability is different. Normal people, we take the same steps as you're walking forward. Alzheimer's patient, very different steps. Different steps cause you to trip up. If you think about it, if you're taking the same step, you don't have to think about it. As you change the amount of steps you're doing. So part, again, as physical therapists know, is trying to improve that step length, get people to do the same step length. Drugs. Drugs are an important cause of falls. The number one drug for causing falls is neuroleptics. You know, those are those antipsychotics that don't work. You know, the ones we give to people because their behavior is abnormal, but they only work for delusions, hallucinations, illusions, and paranoia. They don't work for anything else. Good data to say they don't work, but we continue to give them because we're desperate. So we give a drug that we know is going to kill people, but it's also going to make them fall. Makes them fall, it's not a good outcome. You see that many other of the psychoactive drugs increase falls as well. So we have to use psychoactive drugs sometimes, but be very careful and watch out for them. Basically, if you get rid of psychoactive, psychotropic medicines, you've turned out that you will basically markedly decrease falls. So getting rid of these drugs where possible is very important. Hip fracture. The number one drug for hip fracture are the SSRIs for depression. This is Zoloft, Paxil, Cymbalta, whichever one you like. Part of the problem is they're all very anticholinergic. We got rid of the tricyclics because they were anticholinergic. But the other problem is the SSRIs actually pull calcium off bone. They produce osteoporosis. And we've now got people who've been around for 10 years or so and been getting an SSRI for those 10 years. At this stage, they have severe osteoporosis. And you have to think about osteoporosis in people on SSRIs. SSRIs also basically cause low sodium out of the normal range, which causes delirium. So another reason why they cause problems. What about all that Prilosec and Protonics and everything we have in the nursing home? You know, if you go into hospital, everybody gets on one, they stuck on one forever for no good reason. Usually they don't need it. And basically, they interfere with calcium absorption. They also alter the way the osteoclast works in the bone, increasing the destruction of the bone. That combination together increases the risk of hip fractures. So when people come out of hospital, you've got to say, do they really need this Protonics? If they don't need it, get them off. If they need something, start with something like ranitidine, which is a safer drug in multiple ways, and see if you can get them down to Tums when they have a little bit of indigestion. There are people who have to have these drugs. They have saved people's lives. So there are, but they're a small percentage of people. It's not everybody in the nursing home. So as Nancy Reagan pointed out, just say no to drugs, but truthfully, the drugs you should be saying no to are anything a physician writes a prescription for. Make sure first that that's an appropriate prescription. Also make sure it's the cheapest possible drug. Physicians have this great desire to order the most expensive drug when the cheap ones work just as well. So my rule of thumb is anybody who's on a drug that costs more than $4 a month most probably doesn't need it. And most of the time I can take somebody who comes in with 20 medicines, and besides getting rid of half of their medicines, all the others I can put on as $4. There are exceptions. Sometimes you need the other drugs. But remember, Fosamax is $4 a month now, you know, so that's bisphosphonates. Very cheap. So you don't go and give Residronate, which is basically for a year $1,200. Doesn't work quite as well as Fosamax, okay? So think about this before you do some of these things. Recognize people with diabetes are much more likely to fall. They get into trouble all the time. You've got to pay attention to this. They're also more likely to have injurious falls. This is despite the fact that diabetics have bigger bone. So they have big bone that is not good bone. So when we measure bone, you tend to measure the DEXA, how big the bone is, but there can also be weak bone that is big bone, and you need to be aware of this. So just making the point that type 2 diabetics have increased risk of fragility fractures, and we need to pay attention to this. And a big piece of falls in diabetics is because physicians think they should get the glucose way down. If you get the hemoglobin A1C below 7 in a nursing home or in the community for an older diabetic, you're more likely to kill them, and you're much more likely that they'll have falls. We now recognize you want your hemoglobin A1C in older people, and most probably even in middle-aged people, somewhere around 7 to 7.5, maybe even higher if they're on insulin. So this is a change. I'm an endocrinologist. I run endocrinology at SLU, and it's killing me to realize that I overtreated people for a long time. And you've got to back off a little bit. We can't, because they get hypoglycemia, and hypoglycemia is bad for you. Was that a question or just your hand floating? Okay. Okay. Lower extremity weakness. Don't have to tell the physical therapist in the group. One of the major reasons for fall. You've got to work on lower extremity weakness. Now, one of the things that is developing are vibration platforms. Now, vibration platforms are not as good as a physical therapist. Let me make this very clear. They were first developed by NASA for space flight. They work, but they don't work nearly as well, and you've got to go a long time to get the same effect. But adding vibration platforms in your nursing home, if they can afford them, when you're not doing physical therapy, will be a plus. So you stand on this vibration platform and does that. There are none that are developed that are really safe. So the problem is, if you're sort of functional, they're okay, but for the demented person, for the person with Parkinson's, they're often not safe. I'm trying to get companies to develop one that's got a cage around it and a strap that you can strap the person on so they don't fall while they're in the vibration platform. But they do work. There are a number of studies now in nursing homes saying this is another way that you can do it. It's the same as when you take a stroke patient. You can take the stroke patient, you can put them on a treadmill, and they will get better. They won't get any better than a good physical therapist, but they will get better from doing the exercise.